Hi everyone, welcome back to UWorld's NCLEX review. My name is Samantha. I'm a nurse here at UWorld, and I'm so excited to be back with you all today. Nurse Jackie filled in for me last week while I was boots on the ground at the Florida Nursing Conference, where we had so much fun. We got to meet lots of students just like you. So definitely let us know if any of our viewers were also at the Florida Nursing Conference. Let us know if you stopped by our booth, grabbed a photo, played the question challenge. We're always curious to see which of the students we meet out in the wild follow us back to our live stream. So regardless of if you're tuning in from Florida or from anywhere else, we're so happy to have you. I know that we're moving into November, which really ramps up that fall semester. A lot of you may be just getting over midterms or just about to take some. So we're really ramping up in the semester, which is perfect because today we're going to talk about burn injuries and the rule of 9. So really important critical care concept. We'll have questions sprinkled throughout today's lecture just to check your knowledge along the way. And of course, we have our NCLEX style questions at the end of today's live, so you can kind of get accustomed to the question and answer style of the NCLEX. We always take into account what you all want to see, so definitely let us know the topics, the body systems that you all want to see us present on. Maybe there's something that's been tripping you up or making you struggle in nursing school or while you're studying for that NCLEX. So let us know how we can best help you. After all, that is what we're here for in the first place. So this live will be on demand after we're done today. So if you have to duck out early or maybe you're jumping in and out, you're always able to revisit it on any of our social channels. Personally, I think our YouTube is the easiest one to search because there's a search functionality. As always, drop your comments and questions into the chat. We have Nurse Jasmine standing by moderating for us, so if I run through something too quickly or maybe you want a little more clarification, go ahead and drop those questions into the chat, as well as your answers to today's questions and just any general comments that you want to let us know. We're happy to hear them. So to get that chat started, let us know where everyone is joining from, who here is a US viewer, who's an international viewer. It's always so cool to see just how far and wide UWorld reaches. So with that being said, let's go ahead and get started. Again, we're talking about burns and explaining the rule of 9s today. So starting off, let's define what a burn injury is. It seems pretty intuitive, but we're going to classify it as an accidental injury that leads to direct tissue damage due to direct exposure to either caustic chemicals, electricity, or extreme heat or open flame. So this leads us to our 3 types of burn. Again, a little bit intuitive here. We have a great chart to pull up for you guys, but we have our chemical burns, which are going to be caused by those caustic substances like chemical cleaning products, acid, lye, things like that. Electrical burns, these are caused by electrical currents, no shock there, like electricity coming from maybe a downed power lines, or it could even be something as rare as lightning. And lastly, our most common type of burn, a thermal burn. So this is what we typically think of when we think of a burn injury. Thermal burns are going to be caused by heat. So things like open flame, steam, scalding liquids like a grease are going to be our culprits for a thermal burn. Knowing the cause of the burn, of course, is helpful, but it's really going to guide the role of the nurse in burns is understanding the severity of the burn. That's how we know how quickly, how immediately that we need to intervene. So severity is classified by a few different factors. We classify burns by degree. Most of you have probably heard of burns being 1st, 2nd, or 3rd degree. So we will definitely walk through those next. But how severity is classified is by depth, extent, location, and potential complications. So our 1st and 2nd degree burns is our first one on the docket. We'll go ahead and pull up a great image that you all can screenshot, take with you on your future studies. But a quick review of the layers of the skin as we turn to this 1st and 2nd degree burn image is on top we have our epidermis, the most external layer. Under the epidermis, we have our dermis. This is where the nerves end. Below the dermis, we have our subcutaneous tissue. That's like where a subcutaneous injection would go. It's that fatty tissue. Then we have muscle, and then we have bone. So as we walk through the degrees of burns, the number of degrees is going to correlate with the number of layers that are affected by this burn. So our clinical features, burn severity. With our 1st degree burns, these are our most superficial burns. Our 1st degree is going to be the very top layer of the skin, or the epidermis. This is going to be resulting in superficial redness on the epidermis. Typically, it does not pass through to the dermis or that second layer, it's going to look like blanchable redness, meaning there's still some blood flow here, nerves are still intact. It's typically going to be painful because those nerve receptors are down in the dermis, which did not get burned. We only burned the epidermis. So those nerve endings are still functioning. They're able to send and receive feedback of pain from the epidermis. So very painful, but just our first degree. Now, second degree, or a partial thickness burn, as we see it denoted a lot of the time, second degree mean the injury has penetrated 2 layers of skin. So the epidermis and that underneath layer, the dermis, have both been affected. These burns are going to be painful because, again, our nerves lie in the dermis, which may or may not be damaged from that burn. We're going to see painful blisters. That's a really big clinical feature of a second degree burn, those big blisters that pop up. They develop on the surface of the skin, and the area may be swollen. It can be weeping from that increased capillary permeability from the cellular destruction of the burn. It's as if the cells of our skin were little balloons, and the damage that the burn caused them to pop and their contents start to leak out. That's where we see these blisters popping, leaking, weeping, as we call it. Now, before we move on to third degree burns, I want to ask you all, what's something unique about a third degree burn? And I'll give you a hint here. What I'm looking for has to do with pain. I'm going to give you a few seconds to drop that answer in the chat. But what's unique about a third degree, and I guess a fourth degree burn? Drop that answer in the chat. Alrighty, and y'all did not even need more than a few seconds because Bianca on TikTok already got it, but I was looking for no pain, which we will discuss more as we talk about this. So third degree are also referred to as full thickness burns. We're going to pull up our third and fourth degree burn image for you guys. Again, this is a great visual reference to follow along as we discuss this, but it's the same principle. Third degree means the burn has made it through 3 layers. So we're through the epidermis, the dermis, and now we're into that subcutaneous tissue. Now, third degree burns are going to have significant edema from that increased capillary permeability, which we just talked about releases some of those cellular contents because of cellular destruction from that burn. So these are also going to have eschar, which is just charred skin, that black charred, kind of when you have like a piece of barbecue chicken and you get that burn on the end. For any of our Texas barbecue fans, we're based out of Texas, the burnt end, you can kind of think of it like that. But the unique feature about the third degree is that pain may be reduced due to the destruction of the nerves in that dermal layer, which is the second layer. Third degree, we're into the third layer. So when we destroy those nerves, that nerve obviously is damaged enough that it cannot send and receive sensory information, meaning it can't send and receive those signals of pain. It's not able to accurately sense and relay those pain signals. So a lot of the times this is burned down so deep that these clients don't actually experience a lot of pain from it. Fourth degree is going to be our deepest burn. These are deep tissue burns. Fourth degree, again, you guessed it, it involves 4 layers. So here we're through that epidermis, which is our most superficial. We're through the dermis, through the subcutaneous tissue, and now we're all the way down into the muscles and or that bone. This is a very, very severe, very deep burn. These are largely going to look like that third degree burn. We're going to see our edema, eschar. Again, we'll have that reduced pain from damage to the nerve receptors because we've burned through so many layers of skin. But fourth degree is going to be our most severe. So complications, drop in the chat, what all do you think are complications associated with burns? Let us know, keep them rolling in, and I'm going to keep going through our lecture here, but we're going to pull that burn table back up. A big thing here is a potential complication that we're really worried about because it compromises our airway is an inhalation injury. Now, what is this? These are caused by the inhalation of smoke. It can be from extremely hot air that a client breathes in, or even aerosolized toxins. So we're going to see inhalation injury with both chemical and with thermal burns. These are going to injure the lungs, injure the respiratory tract by causing life-threatening laryngeal and pulmonary edema. That's what we're really worried about here. So what's going to happen with pulmonary edema is gas exchange is going to be impaired due to fluid accumulation within the lungs. Again, it's pulmonary. Now, laryngeal edema is going to take things a step further. So remember, in nursing, our biggest priority is always those ABCs: airway, breathing, circulation. Laryngeal edema is going to potentially completely obstruct that airway because of the swelling in the upper airway that can impede the airway. So when you break these down, we always think about our ABCs. Laryngeal edema is going to be A for airway, it's going to compromise, and pulmonary edema is going to compromise that B for breathing. So both very serious complications of burn injuries. This is why when we identify an inhalation injury that has already occurred, it's going to be critical in caring for these clients with burn injuries. Most importantly is that laryngeal and pulmonary edema may be delayed in presentation. So it's critical to identify that the client received inhalation injuries before it's too late. So we can see that there is inhalation injury. A big sign of this is going to be singed nasal hairs, which wink, wink, nudge, nudge, you may see later in a question. But we want to make sure we identify that inhalation injury so we can keep a really close eye and assess for any laryngeal and pulmonary edema, because we just talked about those compromise the A and the B of our ABCs. The best way to do this is by knowing what signs to look out for. So I just gave one away. I kind of let the cat out of the bag, but definitely let us know any more of the signs of inhalation injury. But clients are at risk for inhalation injuries, can have burns to the face and neck. That's a really big sign, a really big risk for having an inhalation injury. We just talked about the singed nasal hair. Again, this could be related to the thermal burn. So losing our nose hair, having the singed nose hairs because they're exposed to that extreme heat. We can have that soot-tinged sputum from the inhalation of smoke. So we have that dark sputum because this client had to breathe in smoke. Clients can have stridor, which I see a lot of people mention stridor. Way to go. They can present with coughing and wheezing. Remember that we auscultate stridor in the airway, so we're making sure we're closely assessing for this. I see someone ask, can you please explain the rule of nines? That's a fabulous question, Monica. We will get to that at the end of today's lecture, but I promise we're going to go over it in full. Other clients who are at risk for inhalation injuries can also present with oropharyngeal edema or blisters, and they can also have an altered mental status from impaired gas exchange and oxygenation. This is also a sign of carbon monoxide poisoning. Now, carbon monoxide, we know we have those monitors in most homes now. It's released from burning materials. So what carbon monoxide does is when we inhale, it binds to the hemoglobin in our blood and gives us a false sense of oxygen saturation. So knowing this, if the client shows signs of an inhalation injury, we need to treat them with 100% oxygenation via a non-rebreather mask or a bag valve mask. We also need to prepare them for the potential for endotracheal intubation in case we need that. If we don't get them intubated quickly enough and cannot pass the equipment through the airway, then the client may require a tracheostomy for ventilation. If that edema presents really quickly, we haven't gotten that ET tube down through there first, sometimes we're not able to get it in and would have to go down the line to a tracheostomy, which is not ideal. For this reason, we cannot delay identifying and assessing for inhalation injury. We need to recognize these findings, that cough-tinged sputum, soot-tinged sputum, stridor, oropharyngeal edema, or any facial burning, all big signs of those inhalation injuries. We really need to make sure we recognize them early so we can support their airway immediately if needed. So that was inhalation injury as one potential complication of burns. Now let's talk about other things like hypovolemia and hypovolemic shock. So let's walk through how this happens and start with what we know. This seems like a tricky topic, but let's piece it together. So burns cause damage to our cell, which we talked about, which causes the cells to rupture and leak their contents out. And burns can also cause increased capillary permeability. This is going to enable fluid to leak out of the blood system, of the cardiovascular system, and into our tissues. So essentially, you're going to have a massive fluid and electrolyte loss from the circulatory system in the body's blood. And the shift of fluids from circulation to our tissues is something called third spacing. When we have decreased circulating fluid volume, we're going to be at risk for hypovolemia and therefore hypovolemic shock. So when we tie this all together, if we have that decreased circulating fluid volume, we're going to worry about decreased perfusion to our vital organs like our brain, our heart, and our kidneys. And lastly, we're also going to worry about something called compartment syndrome. And it looks like a couple of you already dropped that into the chat before, so way to go. You guys are ahead of the game. But compartment syndrome can happen with circumferential eschar, which means a burn around the extremity. It's a 360-degree burn affecting the anterior and the posterior side. The skin becomes tight and non-elastic. It doesn't have that give to it. There's not very good turgor, and swollen, which prevents blood flow through that extremity, through the torso, wherever that circumferential burn is. It's the same principle for a burn around the chest. So if the skin on the torso is burned and swollen, that edema prevents chest expansion, which means our client can have an inability to expand those lungs. They can hypoventilate. They can have impaired gas exchange when we're not able to fully breathe and ventilate those lungs. Our intervention to treat compartment syndrome is going to be something called an escharotomy, and we have a great what's this called, visual for you all that we can put up. Again, feel free to go ahead and screenshot this, but this is a big intervention for compartment syndrome. When the swelling that occurs below the skin is compressing on the vessels, it's going to impair blood flow. We use an escharotomy to relieve some of this pressure. The surgeon is going to cut into the limb or wherever the circumferential burn is to allow the expansion of the tissue, to relieve some of that pressure, decompress the vessels, and hopefully restore the blood flow. Other potential complications of burn injuries are infection and subsequent sepsis, another major complication we see here. So burns are our really big thing. They're going to compromise that skin integrity. The skin is typically our first barrier to prevent the invasion of pathogens into our bloodstream. But with burns, that protection is impaired. It burns the skin. Skin integrity is compromised. We no longer have this barrier towards bacteria, viruses, any invading pathogens. So these clients are going to have an extremely elevated risk for systemic infection or sepsis, which we know can be life-threatening. These clients are also at a risk for stress-induced hyperglycemia. So due to the nature of burns, our body is going to release stress hormone to deal with the effects of it. This is called cortisol, which increase our circulating glucose levels. So we can have these elevated blood sugar levels or hyperglycemia. Clients are also at a risk for malnutrition. So our body is going to be in a hugely hypermetabolic state to try and heal these burns. It requires a lot of energy to heal. Our metabolic demand will greatly increase as our body fights to provide the energy to respond to the trauma of the burn injuries, to heal from the burns. It's going to be consuming lots of energy, breaking down lots of protein as fast as it can to try and repair this damaged tissue. As a result of this, when that metabolic demand skyrockets, we're not always able to eat and to gain enough nutrition to keep up with that demand. Next, we have mobility issues as a potential complication. So this can result from prolonged immobility due to the nature of the burns, but also from damage to the underlying muscle. So if we're getting into that 4th degree that burns all the way down into the muscle and potentially the bone, this could also cause mobility issues. It can also cause contractures or the shortening or tightening of the muscle, which limits how much we're able to move an extremity, for instance. Alrighty, so that sums up our complications section. Before we get to the nursing intervention section of our lecture, let's talk about the rule of nines. And a couple of you already asked about this. You guys are way ahead of the curve, way to go. But the rule of nines is used to calculate the total body surface area that's impacted by the burn, essentially how much of our body was burned by this thermal burn, chemical burn, or electrical burn. The reason we need to know this is because fluid resuscitation is going to be a huge part of how we treat these clients, but we need to know the total body surface area, or TBSA, that was impacted before we can calculate the amount of volume that we need to replete and replenish the circulating fluid volume in these clients. So we're not going to cover the fluid resuscitation calculations today, things like the Parkland formula that a couple of you guys already asked about. But interesting thing here, we're based out of Dallas. Parkland is a hospital in the Dallas area. So definitely something close to home. I'm sure you'll go over this in your nursing school curriculum. So what we do need to know about the rule of nines is it calculates the amount of TBSA, total body surface area, that's impacted by that burn injury. We call it the rule of nines because each body part is either considered 9 or is a fraction or a multiple of 9. So it's part or it's multiple. You have to be sure that we're considering both the anterior and the posterior side, so the front and the back of this client, because all of that can be affected by the burn. So some examples of this, and we can pull up our rule of nines image here, is that our head is going to be 4.5% on the face, the back of the head and the back of the skull, another 4.5%. So we just kind of divide that in half. Again, 4.5 is half of 9, so that's a fraction of 9. The front of our legs would be 9%. The back of the legs would be 9%, and that's for each. So the right front leg is 9%, the right back leg, posterior side is 9%, and same on the left side. So if you burn one of your legs all around circumferentially, that's 18% total. We also have to include the front of our torso is 18%, the back of our torso is 18%, so a full torso 360 circumferential burn would be 36% of our TBSA. One arm front and back is 9%, meaning that just the front or just the back would be 4.5% respectively, and our groin area is the last 1%, bringing this all, of course, to 100% if you add it all up, anterior and posterior. All right, so our nursing interventions, a couple of things to go over here. We want to make sure we position the client in the high Fowler position if they have a suspected inhalation injury until we can get them intubated, just to help with some of that potential edema that can come on. We want to remove any clothing and jewelry around the burn area, especially with our chemical burns, because those chemicals are going to sit in the fabric, soak in, and they can actually continue to cause burn damage if we leave them on the affected area. So what do we do when the clothing gets stuck to the burn site? If it's stuck to the burn site, it will not easily be removed. We leave it there and we remove what we can around the site. If we try to pull or tear, we can actually cause more damage to the skin. We can go down another layer, which we don't want to do. After that, we would flush the area with cool water, not cold because that can also damage the skin, but we want to keep it cool. Cool water is going to help stop any additional burning. Once we secure the airway in a client with an inhalation injury that would need that, we have done some quick initial interventions to the burn site. We also want to focus on those IV fluids, which is really important to prevent the hypovolemic shock that we talked about earlier. So again, we talked about that major fluid shift from circulation to our tissues, or the third spacing, and that we need to worry about hypoperfusion to the body's vital organs. We also need to consider inserting an indwelling urinary catheter like a Foley, and we need to make sure we're monitoring our I's and O's with this IV fluid resuscitation. We also want to protect the client's urinary tract if they sustained a genital burn. We're going to connect these clients to continuous ECG monitoring. So the release of those cellular contents into the bloodstream is going to alert us that we are likely going to have increased circulating potassium or hyperkalemia. And I just saw someone put this in the chat too. Way to go, you guys. And we need to monitor for any concerning dysrhythmias, because we know that potassium imbalances in the blood comes along with cardiac complications. So we're going to need to treat these clients with lots of pain management. If you guys have ever gotten burned before, maybe you just put your finger on a hot stove by accident, you know it's so painful. If you can imagine having this through, 15, 20, 30% of your body, this is incredibly painful. So we're going to need to treat that pain with some IV opioids, some analgesics, both in the acute stages of treatment and down the road, especially when we do dressing changes, that can be particularly painful. So we also want to pre-treat that pain by medicating maybe 30 minutes or an hour before a dressing change. And we really need to make sure we're maintaining normothermia in these clients. When that skin integrity is compromised, we can have a lot of heat loss. We want to minimize that with a warm environment, warm blankets. Again, our skin helps us regulate our core body temperature. And if that protection is damaged, we can experience that hypothermia. If anyone here has ever been in a burn unit, maybe a burn ICU, you know it's hot in there. It is warm. It is uncomfortable for a normal person used to like a 60, 70 degree AC kind of condition, but they keep those burn units pretty warm. We also want to administer an immunization to these clients. Do you guys know which immunization I am talking about? What are we most concerned about? So we have a burn client. What do we have to make sure that they are up to date on? We give them another one. Go ahead and drop that in the chat. I'll give you a few seconds to drop the immunization that is important to give a burn client. And right off the bat, way to go, you guys. You absolutely nailed it. I see Olivia got it right, Kirsten, Jess, way to go, you guys. It looks like Coco got it right too. But tetanus, we have to give that tetanus immunization, especially if the client is not up to date. Tetanus is a very dangerous infection. It lives in the dust, the soil, and other particles that can enter our system when we have that impaired skin barrier from the burn. So we need to make sure the client is up to date on this, and if not, we would give a tetanus booster. When the client is stable, we also want to promote a specific diet, a diet that's high in two different things. What are our most important nutrients to give a burn client once they're stable? I'll give you a few more seconds to drop that in the chat. You guys have gotten all of these questions right. Maybe I can stump you with this one. But I see one of those nutrients you guys already got, and that was protein. Fabulous job. Protein plays a big role in any kind of healing, wound healing, bone healing, whatever it is. So protein I see in spades, lots of protein. Way to go, you guys. And I haven't seen anyone else get the second one right, and that's going to be carbohydrates to give the body energy for that tissue repair. So want to make sure we have an increased metabolic demand to recover and to heal from these burns. We want to make sure we nourish these clients with lots of protein, lots of carbs, lots of energy so the body can heal. And last but certainly not least, we also want to offer these clients emotional support. So these clients are going to experience a lot of emotion during the treatment and recovery, especially if these burns have impacted their appearance or dramatically changed their life. Maybe their mobility has changed. Maybe they burned their face and their appearance has been altered. There are a few surgical procedures that a client with a burn injury may experience. Now, as a nurse, we're of course not going to perform these, but we will prepare the clients. So we need to make sure that we know our basic pre-op care principles. So these procedures include like a surgical debridement, which is the cleaning of the wound. We can also have a surgical excision or graft. So skin grafts are common in burns to cover the damage. They may grow the graft. They may take it from a different area of the client's own body. And lastly, we already talked about that escharotomy in case the client develops that compartment syndrome. All right, so final section, teaching. Last section, we're almost there. We are going to talk about teaching for these clients when we get to finally discharge them. So these clients may require physical therapy or occupational therapy to rehabilitate. So we always want to encourage this, especially if their mobility is affected. We want to teach them about splints or compression garments to prevent swelling in the affected area or extremity. And we want to teach them about wound care, things they need to know and ensure they're equipped to manage their wound at home as prescribed by their provider. We can teach them about antihistamines and that they can take these to manage itching as we have the regrowth of that epithelial tissue. Sometimes the skin regrows, it can be really itchy. We definitely don't want them to, excoriate that skin, scratch it, so we would give them an antihistamine to deal with this. Also super important, never forget the sunscreen. We want them to be protected from skin damage, especially to a burn site or a skin graft site. If they're still burned, they should be avoiding the sun. If they have a skin graft that's healed, really important to make sure we keep sunscreen or long sleeves, long clothing over it in case we're getting out and exposed to the sun. And we also need to make sure their psychological needs are met. They have the mental health resources available to them should they need them. So with that being said, that's the end of our lecture material. Let's move on to the fun part, and those are our questions. So our first question, question number 1, does require a little bit of math. It is a total body surface area question, the rule of 9s. So here the nurse is caring for an adult client with partial thickness burns to the posterior torso and the anterior and posterior surfaces of both the right arm and the right leg. So a lot going on here. Using the rule of 9s, what percentage of TBSA, or total body surface area, should the nurse document? Record your answer as a whole number. I'm gonna give you a few seconds to go ahead and do some math. Maybe you have a calculator handy. You do get a calculator on the NCLEX, so that's great. But let me know what percentage, it's a whole number, no fractions, what percentage TBSA is affected here. And remember to break up anterior and posterior. So the front of the arm is going to be 1%, the back of the arm is going to be 1%. And I think we have a little guy here in the question, but definitely use that to your advantage. And sometimes I think with math questions, it may sound old school, but the best way to do it, pen and paper. At the NCLEX, you're going to get a little dry erase board. If you want to write it down, I think that really helps you to see it and to prevent mistakes. Alrighty, I see a blend of answers. So this one did seem to trip us up a little bit. So let's walk through it together using our handy dandy TBSA guy that we see in this question. So remember, we have the posterior torso, which is going to be 18%, that's just the back. We have the anterior and the posterior of the right arm. Each of the anterior and the posterior is going to be 4.5% respectively. So 4.5 plus 4.5% equals 9. And then we also have the anterior and the posterior of the right leg, each of which is going to be 9%. So 9 plus 9 is 18. When we group that all together, we have 18 from the torso, just the posterior. We have 9 from both sides of the right arm, and we have 18 from both sides of the right leg. 18 plus 9 plus 18 equals 45. So 45% was our total body surface area affected by this burn. These can be tricky. I think they take a second to kind of get a hang of, but once you get the hang of it, it really kind of simplifies it yourself. So if you struggle with that one, do a little bit more practice. We're going to show you exactly how to go into the Q Bank and get more questions specifically on burns. So I think once you do maybe 5 or 10 questions, it really gets a lot easier. Alrighty, question number 2, our final question of the day. So here the nurse in the emergency department is assessing a client who has full thickness or 4th degree burns to the torso and the upper extremities. Which of the following findings would require immediate follow-up? This is a priority question. So our options are a singed nasal hair, the presence of eschar, +3 edema of the upper extremities, or decreased sensation over the burn areas. And again, ABC is always kind of our bread and butter of nursing questions. What are we most concerned about here? I'll give you a few more seconds. Alrighty, and tomorrow we head out to NSNA in Columbus, Ohio. It's their mid-year conference. We're giving 8 hours of dedicated NCLEX review in person. We're so excited for it. But we do 2 conferences with them yearly, the spring and the fall. We were at Seattle in April, and tomorrow we leave for Columbus in Ohio, which we're so pumped for. If you guys, excuse me, got a little hiccup there, can't make it in person, if no one here is joining us from Ohio, maybe the Columbus area, we also have 6 virtual webinars that we put on through the NSNA throughout the year. We have finished for the calendar year of 2025, but we will be back up and running next year in 2026. So make sure you keep a lookout for those on our social media or on the NSNA's social media. And if anyone here plans on going to NSNA, let us know in the chat. Raise your hand, send us a thumbs up. We're so excited to go, and we're so excited to meet all of you guys. All right, so luckily I see almost all correct options. Fabulous job, you guys. But that singed nasal hair is what we're concerned about because this is a red flag for inhalation injury. We know that is going to compromise the A or the airway of our ABCs. That's why we are most concerned about it. The other ones are going to be expected. We know we're going to see eschar in a 4th degree or full thickness burn. We know we're going to see edema because of that capillary permeability and the 3rd spacing. And because the 4th degree burn goes through that dermis, we know that we can have decreased sensation because we burn through those nerve endings. So again, option 1 is going to be a sign of a complication. It's going to be at risk for an inhalation injury, which is going to compromise our airway. So someone asked why. Singed nasal hair is a big sign in a burn client of an inhalation injury, which means we can have airway compromise, we can have swelling, laryngeal or pulmonary edema. So that is going to be our priority. Great job, you guys. We're going to be back on Wednesday with newborn questions. We're not going to have the 11 or the 3 p.m. live on Thursday, but we will be going live on Friday at 7 with Nurse Andrew in a pharmacology question drill. Here's a quick look at our Q Bank. For anyone that's already purchased the UWorld product, here's how you can target exactly what we talked about today. Simply click these boxes in the Q Bank to get more burn-specific questions. For anyone who has not purchased UWorld, here is just one way that you can filter the questions to target exactly what you want to get better at. So definitely take a look and keep it in mind for when you hopefully do purchase a UWorld product in the future. So in closing, thank you so much for tuning in today. You guys did so fabulous. We will be back tomorrow at 11 a.m. and 7 p.m. and then again on Friday and Sunday at 7 p.m. So a little bit of a different schedule this week, but in case you're ever wondering when we're going live, uworldnursing.com has our full schedule on it, so you never have to miss a live. But thank you so much. This was a long one, but you guys did a great job, and I hope you have a great rest of your day.